Hola, muy buenas tardes a todos en esta nueva edición de la webinar del canal SEMI. En este caso vamos a tratar el tema de la enfermedad renal diabética y para ello tenemos a dos ponentes de lujo. En este caso es una webinar internacional. Inicialmente mi compañero, el doctor Miramontes, internista del Servicio de Medicina Interna del Hospital de Salamanca, pues nos hará una introducción sobre el papel de la enfermedad renal diabética y posteriormente daremos paso al doctor David Cherney, que nos hablará profundamente sobre la enfermedad renal diabética, la situación actual y hacia dónde vamos y todos los beneficios que estamos teniendo por los nuevos fármacos. Al doctor Miramonte lo conoce todo el mundo y al doctor David Cherney, él es nefrólogo, es profesor del Departamento de Nefrología y Medicina de la Universidad de Toronto y él ha trabajado en fisiología renal y ha participado en algunos de los ensayos clínicos de todo esto, de enfermedad renal crónica. Good afternoon for us and good morning for David Cherney. Welcome to stay here. I'm very excited to listen your talk for our society. The Spanish Society of Internal Medicine is really interesting. It's a big opportunity to share this webinar, this streaming with you. And I think it's really interesting your research about the diabetes chronic disease. Okay, good morning. At first, Dr. Miramonte, I'm going to do an introduction, and then I give you your turn to start your talk. Okay?
Perfect.
Cuando quiera, Dr. Miramonte.
Gracias, Javier. Hola a todos. Es para mí una suerte y un placer poder compartir pantalla y con todos compañeros y amigos, con David Cherney, con quien tuve la suerte hace unos años de compartir unos correos electrónicos de lo que salió en Trabajo. No me voy a liar mucho y voy a dejar disfrutar de quién es, pues, la estrella invitada. Entonces voy a hacer un breve resumen de apenas unos minutos de la enfermedad renal en nuestros pacientes diabéticos y un poco cómo está representada. Hi David, it's a pleasure for me to stay with you in a meeting. A few years ago we shared a few emails and we could publish an article together, and now I can stay here with you. I only going to spend a few minutes and then of course, I will enjoy with you. Thank you so much. Como todos sabéis, los pacientes con diabetes presentan un elevado riesgo de enfermedad renal, no es ninguna novedad, y la diabetes sigue siendo el motivo más frecuente de progresión de la enfermedad renal terminal en muchas zonas del mundo. Esta imagen que hemos compartido en la reciente reunión que hemos tenido también subrayaba que sigue siendo, porque ha sido, es y probablemente a corto plazo siga siendo una de las principales limitantes y una de las mayores comorbilidades de nuestros pacientes. Y además es un predictor independiente de mortalidad en pacientes diabéticos. Lo es en pacientes no diabéticos y, como no puede ser de otra manera, lo es en pacientes diabéticos, donde de una manera definitiva es predictor en gran medida de complicaciones, morbilidad y mortalidad. Y hemos aprendido, a lo mejor en los últimos años, o lo sabíamos, pero no hemos puesto énfasis en que la enfermedad renal diabética se produce como consecuencia de múltiples vías patogénicas en un riñón del diabético. El mero hecho de controlar la hiperglucemia no nos asegura que haya una progresión, y es desde la aparición de otros fármacos y desde que se ha incorporado no nos engañemos, los SGLT2 y los análogos de GLP-1, que hemos mirado otras vías patogénicas, pues estos fármacos hacían algo más que controlar la glucemia, con lo cual hemos ido aprendiendo también gracias a los tratamientos nuevos. En nuestro medio, en España, por ponernos en contexto, he utilizado para hacer una foto un estudio que se realizó en atención primaria hace 2 años en pacientes diabéticos mayores de 65 años y era una muestra aleatoria de prácticamente todas las provincias españolas, todos pacientes mayores de 65 años, como decía, con una edad media de 76 años y con una desviación que sí que abarca de una manera representativa a los que pueden ser nuestros pacientes. La prevalencia fue prácticamente del 40%. Y creo que la parte negativa de estas observaciones es ver cómo en muchos casos, cuando se decide hacer una foto fija, ver cómo muchos pacientes se diagnostican cuando la enfermedad está avanzada y se han perdido oportunidades de tratamiento y oportunidades de hacer algo por nuestros pacientes. Que la mayor parte de los pacientes estén en un estadio 3A o 3B de las guías que digo quiere decir que vamos tarde en hacer el diagnóstico y no lo tenemos a lo mejor en cuenta en el momento que nosotros le ponemos ese diagnóstico a un paciente, es usted diabético, y a lo mejor nos olvidamos de valorar de una manera adecuada si tienen daño a nivel renal y otros niveles. Hay otros estudios, el estudio de Cole, en el que con una media de edad muy parecida, una diabetes seguida de 7 años y una determinación de albuminuria, se encontró una prevalencia del 34%, con insuficiencia renal y albuminuria igualmente altamente prevalentes. Quise buscar qué pasa en otros países, cómo es esta foto, y había un estudio que me llamó mucho la atención, que es un estudio además bastante citado, de atención primaria realizado por compañeros de Suiza, en la que se utilizaba una edad media de 66 años y con una duración media de la diabetes de unos 9 años y mostró una prevalencia de casi la mitad de los pacientes tenían una enfermedad renal crónica diabética. Es verdad que las maneras de evaluar los pacientes es distinta, pero es llamativo que la mitad de los diabéticos tuviesen ya una enfermedad renal, con lo cual casi es sinónimo, diabetes de enfermedad renal y problemas. Los tratamientos que se utilizaban en casi todos los estudios, y esto es una media, es insulina en un 25%, es verdad que a medida que aumenta la progresión del daño renal, aún más prevalencia de la insulina por lógica, el 70% metformina, el 28% IDPP4, sulfonilureas en una cifra que a mí me llamaba la atención, creía yo que teníamos menos prevalencia de uso de sulfonilureas y el 70% tenían un bloqueo del sistema renina-angiotensina-aldosterona, sabiendo que son los fármacos que hasta hace no mucho eran más eficaces, es una cifra pobre, un 65% estatinas. Decir también que los pacientes con insuficiencia renal y diabetes son pacientes con infinitas comorbilidades, mare magnum. He utilizado un estudio de cardiólogos del Hospital Clínico San Carlos de Madrid, en la que utilizaron una muestra de 336 pacientes con un seguimiento amplio al alta, algunos incluso año y medio. Pacientes con una insuficiencia renal al ingreso y observaron diferencias significativas en todos los factores de riesgo vascular. Los pacientes diabéticos con insuficiencia renal tenían mayor hipertensión, los pacientes diabéticos con insuficiencia renal presentaban más dislipemia frente a pacientes con insuficiencia renal y no diabetes. Mayor proporción de pacientes con una fibra reducida en los pacientes diabéticos, las cifras de creatinina, urea, potasio, alteraciones analíticas más prevalentes. Y en términos de seguimiento durante el periodo, hubo muchos más reingresos por insuficiencia cardíaca y por otras patologías en los pacientes diabéticos con insuficiencia renal. Nada nuevo que no todos sepáis es ponerle cifras. Entonces, nuestros pacientes diabéticos con insuficiencia renal suelen ser pacientes ancianos con una diabetes mejor o peor controlada. El grado de control no siempre influye, como decía al principio, en la progresión del daño renal, pero sí los años, con más de 7 u 8 años de evolución ya presentan insuficiencia renal. Pacientes que suelen ser hipertensos, suelen tener dislipemia, pacientes que son de estos que tienen una carga de tratamientos que pasa 7, 8, 9 fármacos distintos, lo cual dificulta la toma, lo cual dificulta las interacciones. Son pacientes complicados, la insuficiencia renal los va a limitar en muchos casos, además de dosis, eficacia. Pacientes que tienen patología cardíaca y cardiovascular conforme avanza el tiempo, pacientes que acaban teniendo una gran dependencia de sus cuidadores, pacientes con mucha morbilidad, con una pérdida absoluta de calidad de vida, que acuden en numerosas ocasiones a los hospitales y no nos engañemos, nuestro sistema es mucho protector, pero muy protector, pero son pacientes que salen muy caros en recursos no solo económicos, sino también humanos al sistema, con lo cual son pacientes muy complejos, que al final derivan en un acortamiento de años de vida útil. Todo esto que hemos hecho, no hemos podido ofrecer grandes tratamientos. Si nosotros nos vamos a los años del 2018 hacia atrás, básicamente bloqueo del sistema renal-angiotensina, control eficaz de la glucemia en base a estudios clásicos de control intensivo metabólico, pero poco más. El cambio de paradigma lo estamos viviendo a raíz de los ensayos de los ISGLT2, sobre todo, en los que hemos podido decir, oye, pasa algo con estos pacientes, que su riñón no empeora, puede mejorar, y ya hay estudios específicos, no le quito tiempo al doctor Cherny en este aspecto, con lo cual yo creo que lo que queda abierta es una pregunta de aquí a los próximos años que se contestará, pero podemos especular con ella, que es que si los pueden cambiar los nuevos fármacos, la evolución de nuestros pacientes.
Okay, hello, we're here again. Dr. Cherny, I'm looking forward to listen to you immediately. Okay.
Thanks, everybody. Thank you again to the organizers for including me in this, and I hope that next time I'll be able to visit your beautiful country and give you a lecture in person. So hopefully that'll be the case next time. And so it's a pleasure to talk about new treatments for diabetic kidney disease. And we're going to talk about, these are my disclosures in this area. And we're going to talk about the SGLT2 inhibitors, the GLP-1 receptor agonists, and the mineralocorticoid receptor antagonists, which are really the interesting areas in this field in terms of reducing the risk of kidney and indeed of cardiovascular risk too. But today's talk is really going to focus on the kidney and nephropathy prevention. So in thinking about where we've come from in terms of the treatment of kidney disease and really where we're going, we've made incredible progress in this area. And in thinking about where we were over the last 20 years, we essentially focused on achieving glycemic targets, an A1C of generally less than 7%, achieving blood pressure targets of generally 130/80 or less, and then the use of an ACE inhibitor or an angiotensin blocker in people with albuminuria. But really beyond that, we had very little evidence for other therapies to further reduce the risk of kidney disease progression in people with diabetes or indeed with other conditions as well. So we had data from the Renal and the IDNT trials, which were published around 2000, 2001. And these trials, which were really landmark, proved that the use of an angiotensin blocker reduces the risk of nephropathy progression in people with diabetes, but unfortunately, patients still had a tremendous residual risk of around 30 to 40% of going on to develop endpoints over time. And a similar problem existed in people with non-diabetic proteinuric kidney disease who were involved in trials such as the RAIN trial, whereby there was a significant residual risk of progression despite the use of an ACE inhibitor. So this brings us to the point of thinking about, well, it's not surprising that the blockade of the renin-angiotensin system reduced risk but it did not eliminate risk. And that's because there are many other factors that are involved in the progression of kidney disease. And in thinking about the different factors that are involved here, I've just sort of framed them in three major categories. And starting off, because we've discussed the angiotensin receptor blockers and ACE inhibitors, we know that there are hemodynamic factors that are important in kidney disease progression that we target with therapies, including ACE inhibitors and ARBs. The SGLT2 inhibitors are probably also very important in terms of the reduction in renal risk by reducing hemodynamic abnormalities in the kidney. And this may also be how new and emerging therapies such as endothelin blockers work. In trials such as the SONAR trial with atrasentan, which reduced the risk of nephropathy progression, probably in part by reducing hemodynamic abnormalities. In thinking about other mechanisms that are involved, there's also inflammation and fibrosis, which is a common final pathway for how many different pathogenic mechanisms act to cause kidney disease progression. This is important for how RAS inhibitors work, ACE inhibitors and ARBs. This is important for how SGLT2 inhibitors work, how mineralocorticoid receptor antagonists, which we'll talk about today, work, and also how GLP-1 receptor agonists likely work, which we'll talk about in the context of the FLOW trial with semaglutide. And then finally, metabolic abnormalities in people with diabetes. This is again important for the GLP-1 receptor agonists and also important for other anti-hyperglycemic therapies. So this is a summary of many different areas that are important for kidney disease progression, but it also emphasizes why the use of just an ACE inhibitor or an ARB did not prevent kidney disease progression, because there are so many other mechanisms that are still operant even when we use an ACE inhibitor or an ARB. So this brings us to the SGLT2 inhibitors first, which is where we're going to start the discussion today around new and exciting developments in preventing kidney disease progression. And the SGLT2 inhibitors were, of course, first developed as glucose-lowering therapies because they block the reabsorption of glucose into the proximal tubular cells, and as a consequence, they reduce A1C and also induce weight loss in people who have GFRs above approximately 60. And they also have a variety of other effects, including natriuresis. I think what we've come to understand over the last 5 years is that the benefits of these therapies in terms of their kidney protection and cardiovascular protection are largely, if not completely, independent of their effects on glucose control and glucose management. So what are the mechanisms whereby the SGLT2 inhibitors have their protective effects? So there are many mechanisms, and we don't have time to go through all of them today. I will mention them in passing and then also spend a little bit more time on this mechanism, which is the effects on tubuloglomerular feedback and reducing intraglomerular hypertension. So that's one of the mechanisms which has probably been the most studied in detail in animals and humans, but these therapies also have cardiovascular protective effects. And we know that if you protect the heart, then you also protect the kidney, because you prevent, you protect kidney perfusion and prevent against the cardiorenal syndrome. These therapies also lower blood pressure and have effects on energy substrates such as ketones, and by increasing ketones at the level of the kidney, that may also prevent fibrosis. They impact on inflammation and fibrosis related pathways. They impact on ischemia and oxygenation, which may protect the kidneys, and they also have effects on reducing albuminuria and the use of loop diuretics, all of which tend to be associated with renal injury. Albuminuria causes tubular toxicity, and loop diuretics and high-dose diuretics tend to dry our patients out. And so if we use SGLT2 inhibitors in part to prevent the need or the use of high doses of loop diuretics, that may also be beneficial in the long term by maintaining a reasonable level of intravascular volume. So how is it that the SGLT2 inhibitors reduce glomerular hypertension? So this is probably the most important mechanisms by which these therapies are renal protective. And they likely reduce glomerular hypertension sort of like an ACE inhibitor-like effect by reducing glomerular pressure, but through a different mechanism than how the ACE inhibitors and ARBs work. So these therapies are natriuretic and have a glucosuric effect, as I mentioned. And by blocking salt reabsorption proximally, that essentially delivers sodium to this little distal area of the kidney called the macula densa. And by increasing salt delivery to this area, that increases the salt that's reabsorbed by these tubular cells that are highly specialized. That's an energy requiring process. So by reabsorbing all of that salt downstream in the kidney, that essentially breaks down ATP to adenosine. And in this area of the kidney, adenosine is a vasoconstrictor by binding to the adenosine 1 receptor. And so by binding to the adenosine 1 receptor and causing vasoconstriction of the afferent arteriole, which is the inflow arteriole in the kidney, that reduces renal hyperperfusion and also reduces intraglomerular hypertension. So this is one of the key mechanisms through which these drugs work. And this is probably important in people with diabetes and also important in people without diabetes, which I'll show you afterwards. So this is an animal model which shows how the afferent arteriole in an animal with type 1 diabetes responds to an SGLT2 inhibitor. And you can see the afferent arteriole over here is quite dilated at baseline. It's opened up because of a variety of abnormalities that occur in early diabetes. And then in response to SGLT2 inhibition, after only 2 hours after the dose of the drug, you can see that the afferent arteriole is constricted, it clamps down. And that reduces the blood flow into the glomerulus and reduces the mechanical stress and injury of having this high perfusion state in the setting of diabetes in these remaining nephrons. So these therapies are hemodynamically active and they thereby reduce glomerular hypertension and kidney injury. This reflects in terms of the clinical practice that you see, this results in a reduction in albuminuria and also leads to this acute reduction in GFR that you see when you start these therapies, this so-called GFR dip that's seen, and that's because of this vasoactive effects of these therapies. It's an acute effect, it happens after a single dose, and it's also reversible after you stop these drugs. So very important key message to take home with you. But regardless of the mechanisms, we know that these therapies have kidney protective effects clinically. This is from a meta-analysis by Brendan Nguyen, and you can see that in patients with GFRs of over 90, 60 to 90, 45 to 60, and less than 45 across these cardiovascular outcome trials, and this also included the Credence trial, which I'll discuss in a moment, you can see that these hazard ratios are very much reflective of a significant reduction in the risk of either reaching end-stage kidney disease, losing GFR, or ending up with requiring renal replacement therapy or renal death. The risk of having one of these endpoints as a composite was reduced by between 30 and 60%. So very important, significant benefits across a range of GFRs. And then more recently, we know from even the VERTIS-CV trial, which tended to be the most attenuated in terms of the benefits that were seen in the kidney, when we reported this data, and this is currently in press as well, when we reported this data and then used very consistent definitions of kidney disease protection defined by a sustained 40% or more decline in GFR, you can see that across these different cardiovascular trials, EMPERIC Outcome, CANVAS, DECLARE, and VERTIS, that there were significant benefits across these different cardiovascular trials. In the Credence trial, which was the first dedicated renal trial, there was also this substantial 30% reduction in risk of end-stage kidney disease, doubling of creatinine, renal or CV death. Canagliflozin reduced the risk of this composite endpoint significantly, also reduced a variety of different cardiovascular composite endpoints, and reduced the risk of this renal-specific endpoint, end-stage renal disease, doubling of creatinine, or renal death, which was reduced by 34%. But importantly, in Credence, this was a cohort of patients that only included individuals with type 2 diabetes with elevated albuminuria at baseline and a GFR between 30 and 90. So a very specific group of patients with diabetic kidney disease and with albuminuria, a very similar cohort to the trials that I mentioned at the beginning, the IDNT and Renal trials, which tested the effects of angiotensin blockers. So this is important, of course. It's a landmark trial and demonstrated benefit in patients with established disease, but it didn't answer that key question around, do these therapies protect the kidney in people without diabetes? Because many of the benefits and the effects physiologically are actually independent of glucose. So the next key question was, is there a benefit in people without diabetes? And so to start addressing this question, there were first some mechanistic studies that were done, and this is one of the trials that we completed and published last year called DIAMOND. And the goal of this trial was to better understand if SGLT2 inhibition with dapagliflozin led to a reduction in measured GFR, so this surrogate of a reduction in glomerular hypertension, which is an effect that we expect to see on the basis of natriuresis. And so we did this trial in 50 patients with non-diabetic proteinuric kidney disease, just a 6-week trial to see if we could detect changes in proteinuria and changes in measured GFR as a reflection of these hemodynamic benefits that these therapies exert. And so while at 6 weeks we were unable to detect a change in proteinuria that was statistically significant, we actually did see an effect on measured GFR with a dip of around 6.6 mils with dapagliflozin. And remember, these are patients without diabetes. They have an identical hemodynamic effect with dapagliflozin compared to what you'd expect to see in people with diabetes. And this is proof that the hemodynamic effect and impact of SGLT2 inhibition is independent of glucose, because these patients were not hyperglycemic. But of course, the proof that these therapies are ultimately protective comes from the DAPA-CKD trial in people with and without type 2 diabetes who were enrolled in this trial, just over 4,300 individuals with albuminuria, UACR between 200 and 5,000 on a maximum tolerated dose of an ACE or ARB. And I'll review some of the primary and secondary outcomes from this trial. Importantly, patients at baseline had a mean age of 62, about a third were female, 52% white, 5% Black or African American, 35% Asian, 8% other. 2/3 of patients had type 2 diabetes at baseline. So this was predominantly type 2 diabetes, but about a third of patients had other etiologies of kidney disease. And patients had around 1 gram per gram of albuminuria, and most were on a maximum tolerated dose of an ACE or ARB. So this is the primary outcome. So this is defined by a sustained 50% or more decline in GFR, end-stage kidney disease, renal, or CV death. This was presented at the ESC at the end of August, and you can see this and subsequently published in the New England Journal. And you can see that there was a very significant 39% reduction in this composite endpoint, resulting in a number needed to treat to prevent one outcome of only 19. So extremely favorable number needed to treat with a very substantial benefit. Not only was the primary composite outcome significantly reduced, there were significant reductions in the 50% eGFR decline, a reduction in the risk of end-stage kidney disease, and there was a trend towards a reduction in CV death, which did not reach significance, and I'll come back to that in a moment. This is perhaps the most important new data that came out from DAPA-CKD, and you can see in this second row that there was no statistical difference in terms of the benefit, in terms of those with type 2 diabetes and those without diabetes. So it didn't matter if you had type 2 diabetes at baseline, there were significant renal benefits in both groups, which did not cross the line of unity. So really, really important observation from DAPA-CKD. Again, no heterogeneity around albuminuria or around eGFR at baseline either. I also wanted to mention that beyond the reduction in the primary composite outcome, There was also a significant reduction in the renal specific composite. So that's the primary composite without CV death. So just looking at renal hard endpoints. Also a reduction in the composite of CV death or hospitalization for heart failure, and a reduction in all-cause mortality. So although CV mortality wasn't reduced, all-cause mortality was, which is incredibly important because in our patients who end up on dialysis, they often pass away at home, and we often don't know what the cause of death was. So having all-cause mortality is probably more appropriate for a renal cohort such as this. So how does all this impact on what we do clinically? And I think this is important for general internists as well, because I think these therapies are going to be used by endocrinologists, nephrologists, cardiologists, internal medicine specialists, and by general practitioners. And importantly, if you're using them for metabolic effects, it's important to remember that those effects on A1C are really only substantial in individuals with GFRs of over 60. As the GFR declines, especially to a GFR between 30 and 45, there is less filtration because of impaired kidney function. And as GFR goes down, there tends to be less of a glucosuric effect. And so there really isn't very much in the way of glucose lowering or A1C reduction, but there are still benefits for the heart and the kidney, which is what I'll talk about now. But don't expect there to be a big effect on A1C if you are treating a patient with a GFR of less than 45. That's what I'm trying to say. On the other hand, if you're using these therapies for their cardiorenal effects, it doesn't matter if the GFR is less than 30, because these therapies have benefits that extend across the range of GFR. And if the GFR is over 30 or more, and patients are being treated for kidney and cardiovascular protection, then you can go ahead and do that, because there is still a benefit for the heart and the kidney, even though there isn't much of a glycemic effect as the GFR is below 45. Do remember to review glycemic therapies. If the A1C is less than 7 and the patient is taking drugs that can induce hypoglycemia, like insulin or a sulfonylurea, or the patient has a history of hypoglycemia, then we do tend to reduce the insulin by about 10% or reduce the sulfonylurea dose by about half, and then start the SGLT2 inhibitor. And that's to minimize the risk of hypoglycemia that's related to insulin or the SU as a background therapy. If the patient is, on the other hand, being started on these therapies for heart or kidney protection, also think about the blood pressure and the volume status of the patient. And if the volume status is normal or the patient is hypervolemic, just go ahead and start the drug. You don't have to adjust any background therapies. On the other hand, if the patient has hypotension or volume depletion, of course, we would back off on their diuretics or their other blood pressure medicines like their calcium channel blocker, and then start the SGLT2 inhibitor. So it's very simple to start these drugs. Just remember hypoglycemia and volume depletion / hypotension, which are unusual. And once that's corrected, you can start the drug. So I've talked about the Credence trial and DAPA-CKD. There is another trial called EMPA-Kidney, which is ongoing and is enrolling patients with and without diabetes. The unique thing is that the GFR goes down to 20, and in patients with GFRs of between 20 and 45, they don't have to have any albuminuria. They can be normal, micro, or macro albuminuric, which is important in terms of the patients who we see in clinic who are often not albuminuric, and we need data in these patients to know what to do with them and to see if SGLT2 inhibitors work. So that's what I wanted to discuss about SGLT2 inhibitors. I do want to talk about other therapies and remember that there are other pathways that are important, including inflammation and fibrosis and metabolic abnormalities, both of which can also contribute to kidney disease progression, especially in people with diabetes. So the perhaps newest kid on the block in terms of a new therapy are the mineralocorticoid receptor antagonists. And many of you are probably familiar with these therapies in terms of the context of heart failure, but there really haven't been any kidney-specific trials until recently looking at the effect of MRAs on hard renal outcomes. And that's in large part because of the risk of hyperkalemia that these therapies can potentially have, as well as the other side effects such as gynecomastia and breast enlargement. Now, there's a very strong rationale for the use of therapies that block the mineralocorticoid receptor because of the role that the mineralocorticoid receptor has around inducing inflammation, oxidative stress, and fibrosis. So certainly experimentally, there's a lot of data suggesting that if we block the MR, the mineralocorticoid receptor, that can reduce the risk of kidney disease progression. And there were previous smaller studies with novel mineralocorticoid receptor antagonists that were very supportive of these therapies as a potential new kidney protective therapy, specifically finerenone, which is a novel non-steroidal mineralocorticoid receptor antagonist that has greater receptor selectivity than spironolactone and greater receptor affinity or binding than eplerenone. So it's very different pharmacologically than the older MRAs. And there was also data from studies such as the ARTS study in patients with heart failure and moderate kidney disease, whereby there was a reduction in albuminuria with finerenone, which supported additional trials with this therapy that were specific to reducing kidney disease risk over time. And that was the aim of this second trial called ARTS-DN, which was aimed at determining the efficacy and safety of different doses of finerenone on reducing albuminuria on top of an ACE inhibitor or ARB. And in the ARTS-DN trial, which only involved many hundreds of patients, as opposed to thousands who were involved in the Fidelio trial that I'll talk about next. In the ARTS-DN trial, there was this very nice dose-dependent reduction in albuminuria with finerenone, and importantly, from a safety perspective, there was only a risk of hyperkalemia leading to discontinuation of between 1% and 3%. So there was a very reasonable safety profile in this earlier trial with finerenone. So as a consequence, the Fidelio trial was undertaken and randomized just over 5,700 patients to finerenone or placebo. And this was, of course, an event-driven, placebo-controlled trial with primary renal and secondary cardiovascular outcomes. So this is the primary composite renal outcome, which was defined by kidney failure, so either end-stage renal disease, sustained decrease in GFR of less than 15, a sustained 40% or more decline in GFR from baseline, or renal death. And you can see that there was a significant 18% reduction in the risk of the primary composite outcome. And remember, this is on top of an ACE inhibitor or an ARB. So this is on top of standard of care, which is super important in terms of how these therapies will be used in the future. In addition, there was a 14% statistically significant reduction in the key secondary CV outcome defined by cardiovascular death, MI, or hospitalization for heart failure, as well as these other components. And this, as I mentioned, did reach statistical significance. In addition, there was about a 31% reduction in albuminuria. So interesting, because most therapies that tend to be kidney protective tend to reduce albuminuria as well. So a clinically relevant degree of albuminuria reduction. And in terms of GFR, this is a really interesting pattern of kidney function over time. What you can see is by the end of the trial, patients with finerenone had better preservation of kidney function compared to placebo. You'd expect that because the renal endpoint was positive. The patients treated with finerenone also lost less kidney function year over year. They lost about 2.7 mils per minute per year versus almost 4 mils per minute per year with placebo. So also not a surprise because of the protective effect. But what's also really interesting is this acute pattern. What you see is this acute dip in GFR followed by stability and then better preservation over time with finerenone. So what this suggests is that not only is finerenone having an anti-inflammatory effect, there may indeed be protective hemodynamic effects with finerenone as well. And this certainly needs to be looked at in more detail in the future. So very interesting and very promising effects with finerenone. And from a safety perspective, just like with ARTS-DN, there was about a 2.3% risk of hyperkalemia leading to discontinuation with finerenone versus 0.9% with placebo. So relatively low risk of hyperkalemia leading to discontinuation. Of course, the risk was higher with finerenone, but the risk that was serious enough leading to discontinuation was quite low. And of course, less serious degrees of hyperkalemia are seen on the far left-hand side, but that didn't necessarily lead to discontinuation. The rate leading to discontinuation is probably the most important in terms of being able to judge the context and place relative to other trials with older MRAs. So very exciting area from the Fidelio trial, and there is still the Figaro trial, which is ongoing, which is the cardiovascular version of the Fidelio trial with a primary CV outcome, and there will be secondary renal outcomes. So we'll certainly know more about this exciting area in the coming months to year. So finally, I wanted to talk about this, this purple area, the metabolic related pathways in the last couple of minutes, and touch upon the future, which is GLP-1 receptor agonists, which are also extremely exciting as a renal protective potential therapy. So just like the SGLT2 inhibitors, just like the MRAs, just like the RAS inhibitors, the GLP-1 receptor agonists also have a variety of different effects that may be protective in the kidney. They have indirect effects. Of course, they're used for the glycemic improvements, for reducing blood pressure and weight loss, but they also have direct effects in the kidney. They're natriuretic. They may impact on hemodynamics to a certain degree. They block the renin-angiotensin system. They have effects on oxidative stress and inflammation. And all of these may be some of the reasons why we see these very promising signals in terms of kidney protection with the GLP-1 receptor agonists. We know from, for example, the LEADER and SUSTAIN-6 trials that a GLP-1 receptor agonism was associated with a significant reduction in the risk of persistent new-onset proteinuria, which suggests anything that reduces albuminuria is suggestive of kidney protection. We know that there's a strong link between albuminuria lowering and reductions in subsequent loss of kidney function. But importantly, in these trials, there wasn't a signal around protection against kidney function loss in the overall cohorts, and there was no signal around the need for dialysis and reducing the need for dialysis. But remember that these were cardiovascular safety trials. These were not nephropathy trials. So you wouldn't necessarily expect to see a renal benefit in this overall relatively low risk patient cohort. But when the data was analyzed in more detail, especially in the LEADER cohort and subgroup of patients with CKD stage 3, what you do see is this sort of emergence of a signal for kidney protection. So patients treated with liraglutide had better preservation of kidney function over time compared to placebo-treated patients. In other words, the higher risk subgroup tended to have a signal for better preservation of kidney function over time with liraglutide compared to the placebo group. And in subsequent analyses, and of course we have to put together data in post-hoc pooled analyses in order to really look at the signals for kidney protection in patients enrolled in the LEADER and SUSTAIN-6 trials who had CKD stage 3, so GFR between 30 and 60, who had either micro or macroalbuminuria. We really do see this very nice signal for kidney protection. In other words, the patients with albuminuria and CKD stage 3, they had a reduction in the risk of either having a 30% reduction in GFR, they had protection against having a 40% or a 50% or even a 57% reduction in GFR. Patients treated with GLP-1 receptor agonists, they had a lower risk of achieving kidney function loss over time. So they had better kidney protection in these post-hoc analyses in higher risk kidney patients enrolled in these trials. Again, very suggestive and supportive of renal protection. And then finally, we know from the REWIND trial, and this is probably some of the most impressive data and supportive data, that not only was there a reduction in the risk of albuminuria progression, which you can see here with dulaglutide, but in addition, Herzl-Gerstein and his colleagues showed that there was a 30% reduction in the risk of either having a sustained 40% or more decline in GFR, and there was a 44% reduction in the risk of having a 50% or more sustained decline in GFR. So across the trials that I've mentioned, including LEADER, SUSTAIN-6, and REWIND, there is certainly signals that are very supportive that the GLP-1 receptor agonists reduce the risk of losing kidney function that is clinically relevant over the period of the trials. So this is the rationale for the FLOW trial. And the FLOW trial, which is ongoing, is enrolling patients with type 2 diabetes at higher risk of diabetic kidney disease progression, including albuminuria, to semaglutide or placebo in order to see if there is a significant reduction in the risk of kidney disease or cardiovascular disease progression. So the primary outcome is onset of persistent 50% or more decline in GFR, GFR to less than 15 or dialysis, or renal or CV death. So very similar kinds of endpoints to the ones that we've discussed for the other trials during the course of this talk. So what I've talked about today is certainly having an important impact on guidelines, and we know that the recommended first line therapy for patients with diabetes and kidney disease now includes metformin and an SGLT2 inhibitor in patients with GFRs of over 30. Of course, this is now out of date because the DAPA-CKD trial enrolled patients with GFRs down to 25. So we should really be thinking about 25 as the magical number, not 30 now. And these therapies should be continued down to the time when patients have either a GFR of less than 15 or dialysis, just like what we would do with an ACE or ARB. And then the GLP-1 receptor agonists are now preferred on top of that because of the benefits that I've shown you today. And that's ultimately being tested in the landmark FLOW trial, which will better determine if there is indeed benefit from the heart and kidney perspective in people with established kidney disease at baseline. So I'm going to end there. We have lots of time for Q&A, and I'll end with the following thoughts: that the SGLT2 inhibitors have these pleiotropic effects that are beyond glucose lowering. We know that from DAPA-CKD that we've talked about today. There are also heart failure trials that we didn't have time to discuss during the course of today's talk. And we've also talked about exciting data from Fidelio and GLP-1 receptor agonist studies, which are being looked at in ongoing trials, including FLOW and others. And we also have to think about how to implement the results of these trials in our patients to effectively and safely prevent kidney disease progression in the patients who would have been included in these trials. And I'll look forward to hearing your thoughts about that during the course of the Q&A. I also want to thank my collaborators and funders, especially for the work that I've discussed today. And I'm looking forward to hearing your questions and comments. And thank you again so much for including me in your conference.
Thank you for it. I'm fully excited because of your talk. Congratulations. I have several questions. We have about 10 minutes or a bit more. My first question is about, because it's interesting, your relationship between inflammation and metabolics and hemodynamic mechanism to explain the result in kidney disease. But if SGLT2 is more important in inflammation, as you said, and GLP-1 in metabolics, do you think we have enough evidence to use the combination of these drugs in chronic kidney disease, or it's a good idea to have a clinical trial using both drugs? What is your opinion?
Sure. Yeah, great questions. And so it's hard to know that because of the era of the trials. When these trials were completed, very few patients, for example, in the LEADER and SUSTAIN-6 and REWIND trials were actually being treated with an SGLT2 inhibitor at baseline, because so few patients were taking them when the trial was designed and performed. So we don't know for sure if there is any if there is synergy or added benefits with these therapies. We do know from trials such as some of the surrogate marker trials like Duration 8, whereby the aim was to use them together or alone, that the addition of an SGLT2 inhibitor with a GLP-1 does reduce weight and blood pressure and A1C more versus either drug alone, but we don't have data around endpoints and about whether there is added benefit. Nevertheless, the mechanisms are likely synergistic, especially hemodynamic with the SGLT2 inhibitors and perhaps inflammation, fibrosis, and metabolism with GLP-1RAs. So we do use these therapies in combination for mainly diabetes-related reasons, but ultimately we'll only know whether there is benefit together from the FLOW trial, where there will be patients on both therapies, and we'll have a much better idea if there are added benefits or not.
Okay, thank you. I have several questions for the audience.
Sure.
Okay, one of them is about the oxygen consumption. As you know, this is a crucial mechanism in chronic kidney disease and use of the GLT-1 too. And do you think that in no-diabetes patient, this phenomenon is not proof? What is your opinion about that?
Sure. So there is one trial that involved people without diabetes that was published in JAHA by Zanchi, Z-A-N-C-H-I, that was published about a year ago or so, and it looked at people with no kidney disease and no diabetes, and looked at bold MRI, which is a way of looking at oxygenation in the kidney, and they actually did not show an effect of SGLT2 inhibition in people without any kidney disease and with no diabetes. So I think it's hard to show a benefit or an improvement in oxygenation in a healthy group of patients because they don't have hypoxia. So why would there be any improvement in hypoxia? Because they don't have any abnormality to begin with. But I think the proof will ultimately be in terms of whether there is an effect and a benefit on ischemia. There are ongoing studies using bold MRI and other techniques in people with diabetes, and I think that's where we'll ultimately show benefits around oxygenation. And similarly, in people with albuminuria and GFR impairment, that may also be a setting where we see improvements in oxygenation and a reduction in ischemia. But I think the jury is still out. We just don't have the data yet to prove that one way or the other.
Okay. Another question for the audience say that what is the evidence or your practice in use the SGLT2 and GLP-1 in patient over 80 in elderly people? Is that useful?
Yeah, definitely. So we do use them. You have to pick and choose your patients, and there is data and sub-analyses from the large outcome trials looking at patients over the age of 75, and there doesn't seem to be any difference around either efficacy or safety. So we do use them in patients who are over the age of 75, including those over the age of 80. But you have to use your clinical judgment around how to monitor them, especially around the use of other medications and whether you back off on other therapies like diuretics, for example, before you start the SGLT2 inhibitors. I have to admit, for my GLP-1 receptor agonists, I also use them in people over the age of 80. I'm much more tentative around the dose that I go to. I tend to go up a little bit more slowly to make sure that it's tolerated well, to avoid excessive weight loss, because there's such incredible drugs around the weight loss effect that we want to make sure that patients don't lose too much weight as well. And so I do tend to titrate the dose a little bit more slowly in elderly patients, but I think there's again good safety and efficacy data. I just I'm more tentative around going to the maximum dose to avoid excessive weight loss.
Okay. Another interesting question said that do you think that SGLT2 impair kidney function in the long run because of the exposure of the high glucose in the distal nephron? Because clinical trial stopped in a short time of period. What happened in 10 years?
Sure. So very important point. So we now have data from over 50,000 patients who have been in trials, including heart failure and kidney disease and so on, showing that these therapies are clearly, beneficial from a heart perspective and kidney perspective. The question is, if you use it for, say, 25 years, is there any signal for any issues? And the trials can't answer that question because we have data that essentially goes up to around 5 years. And again, there's protection over that period of time. But we do have data from patients who have a condition called familial glucosuria, which is a genetic abnormality whereby patients spill glucose in their urine for their entire lives, and since the time they're born, because they have basically a genetic knockout of SGLT2. And we know from these families and these cohorts of patients that there is no signal for concern or danger or longevity, cardiovascular risk, or kidney risk in patients with familial glucosuria, where they're actually spilling out much more glucose because they have a knockout. So they don't just have a partial effect that's pharmacological, they have a complete effect with much higher levels of glucosuria. And again, there's no safety issue. So I think we know from the trials and from these issues that have come up in nature that there is no signal for renal injury, and in fact, they're markedly kidney protective.
Okay, this is a very short and practical question. And what rate or glomerular filter rate we should stop ACE or ARB?
When should we stop them? So typically we continue them. So I typically start ACE inhibitor or ARB therapies when the GFR is over 30 approximately, because that's typically when I'm referred the patients. I sometimes start them when the GFR is 25 or higher, if there's an indication to, but I just continue them as long as the patient tolerates the ACE inhibitor or ARB. We continue them even when the patient's on dialysis, because I always think about the fact that these therapies are not only beneficial for the kidney, they're also beneficial for the heart, around heart failure and blood pressure. And so we continue them as long as the patients don't develop hyperkalemia or other issues related to their ACE inhibitor or ARB. We continue them even on dialysis.
Okay. Pablo, do you want to ask?
Thank you. Thank you so much. I want to make a question as how long time we need to wait to use these drugs in no-diabetic patients, like renal protective agents? I think.
Sure. Yeah, so in terms of the use of these therapies in people without diabetes, so many of it, so right now around the world, there isn't an approved indication for people without diabetes. But I think that based on the DAPA-CKD trial, many physicians, especially nephrologists, are using these therapies in people without diabetes for kidney protection, and they're also being used in heart failure patients because of the benefits that have been seen in EMPA-KIDNEY and DAPA heart failure. So in those with reduced ejection fraction. So I think the time is now, and if you feel you have to wait until the indication and regulatory approval is in place, I guess that is a personal decision. But I would always discuss it with your patients to tell them what the evidence is and the reasons to and not to start one of these therapies. The data is so overwhelming that in patients with indications who can get access to these therapies, and access is an issue around cost and insurance and so on, then I think many physicians are starting these therapies now, as long as the patient would have gotten into the trial. If they would have gotten into DAPA-CKD, for example, I think a lot of physicians are starting these therapies now, as long as the GFR is over 25 and the patient has albuminuria. Yeah, pleasure.
Okay, I have, I think the last question, and I think it's the 1 million question is,
sure.
What about the use of SGLT2 in patients with under 25 milliliters of glomerular filter?
Yeah, sure. So it's a very important question, and of course, as you know, we don't really have data right now to tell us what to do in patients with GFRs of less than 25. The EMPA-KIDNEY trial will ultimately tell us the answer to that, which we'll hopefully have results from in the coming couple of years. But in the interim, if you have a patient with a GFR of 24 or 23, the question is, are you going to extrapolate the data from these trials down to a GFR that's less than 25 in someone with albuminuria? And I think that's also a discussion you have to have with your patients. There are definitely nephrologists who are starting these therapies when the GFR is between 20 and 25, because they think that a GFR of 22 or 23 or 24 is not different than a GFR of 26, and they're probably right. We don't have data for it, so I think that's also an important discussion to have with your patient, to say, we have data in patients with GFRs that are higher. We can extrapolate, but there is some unknown around it. I think where we shouldn't be extrapolating yet is someone with a GFR that's low, especially below 30, who doesn't have any albuminuria and just has low GFR. We really don't have data in those patients to use these therapies in that setting, because those patients would not have gotten into any of the trials that we have. And I think in those patients with low function, but with also no albuminuria or really low levels of microalbuminuria, I think that we really have to wait for the EMPA-Kidney trial, which will answer that question definitively in the coming couple of years. So I think that's where there is a clearer answer. I think in people with albuminuria, there is certainly more of a discussion that needs to take place between physician and patient to come up with a common solution about what to do.
Okay, we don't have more time, unfortunately. I fully enjoy listening to you with your terrific talk. Okay, thank you very much. We can see in other meeting.
I'll look forward to it. Thank you again for including me. It's really good to see you both.
Thank you so much.
Take care.
Bueno, con esto despedimos ya esta webinar.